Thank you, Dr. Nurul, Dr. P.P. Kannan sir, and Paneer Selvam sir. Thank you very much for giving me this opportunity to be here. I will just take a minute to share my screen. Can someone confirm that my slides are visible and I am audible?
Yes, sir.
Yes, doctor.
Okay. So once again, thank you to the organizers of this wonderful webinar series, which is just already completed a couple of sessions and on a Sunday morning. Thank you to all the delegates for spending their valuable time here. So I am going to speak over the next half an hour to 40 minutes on suicide risk assessment and formulation, and try to simplify and maybe also demystify this process to go in a very structured manner, because what is important is, I think those of us who have spent sufficient years in the field will appreciate the fact that despite our best efforts, there'll always be patients who die by suicide under our watch. But whether we are doing all the things that are within our power and whatever evidence tells us in order to properly assess, in order to do what is called a therapeutic risk assessment, triaging, and formulation and management. That is the key here. So my entire presentation will be structured around, will be highlighting how we should follow a structured process to this approach so that we cover all the bases. So the outline of my presentation will be, first we'll just briefly talk about the need for risk assessment, and then what is the difference between risk assessment and risk formulation, the various elements of suicide risk assessment, which is really the most important part of the presentation. What are the various domains that a clinician has to cover when they do a suicide risk assessment? And then there are many models for formulating suicide risk, but we'll just be discussing two important, recent, accepted, and evidence-based models for SRF, that is suicide risk formulation. And then I actually do this as a half day or even a full day workshop on suicide risk assessment and formulation, where we discuss a lot of case vignettes and how to formulate the risk and all. But I thought at least one case I can show at the end of my presentation, and we can throw it open for discussion so that all of you can also pitch in with some ideas about what are the domains that are highlighted in that case vignette, so that we try and apply our knowledge about what we discussed. Now, Dr. Nurul also mentioned that some questions and prizes will be given. So I would request you to, I will be asking numerous questions. I don't know whether it's just 3 or 4 which I've prepared, but I've prepared, they'll be asking numerous questions during my presentation. It will be very nice if somebody can unmute and answer or, post in the chat box. If you unmute and answer, it will be better, because when I am presenting, I cannot follow the chat box. And it kind of gives a better interactive feel if somebody can unmute and answer. Do not worry if you are, there are practically most of you are always going to be right in your answers. There is no really right or wrong answer in many of the cases. And so whatever you tell is fine, and you give us an opportunity to perhaps discuss more on that. So with that, we will begin the first segment, that is what is the need for risk assessment. So if we see the evidence, it tells us that in the year prior to death by suicide, most suicide decedents, more than 3/4 of suicide decedents, have contacted a healthcare provider, which may be a primary care provider or a specialist care provider, prior to their death, in the year prior to their death. And about 1/3 have contacted a mental health professional in the year prior to their death. And about 1 in 10 individuals have been seen in the emergency department within 2 months prior to death. So what does this tell us? This tells us that whichever way you look at it, there are significant opportunities for healthcare providers like us to identify individuals who are at risk for suicide and try and engage them in strategies designed to decrease the likelihood of suicidal self-directed violence. However, despite there being significant opportunities for identifying such individuals, most of us at various times, including myself, we have grappled with the feeling that we are lacking in the training and skills that are required to assess suicide risk comprehensively and competently, despite most of us will agree that this is a core competency for professionals like us. So despite this, I think not enough emphasis is being given to this aspect while training. So this is probably the reason why most of us may feel a little deficient in this area. And this was also brought out very nicely in a joint commission sentinel event report published nearly a decade ago, where they analyzed about 600 odd inpatient suicides. Now, remember, an inpatient suicide is a never event. So if you know the classification of events in patient safety, we talk about never events. That is, these are events which should never occur. Another example of a never event is maternal mortality. So similarly, suicide in inpatients is a never event. But when they reviewed the files of nearly 600 odd inpatient suicides, they found that there was some or the other lacunae in assessment of suicide risk that could be linked to the death by suicide, and that was the leading cause of hospital-based suicide. So that is a very, a chilling reminder of the need to upskill ourselves in this area, all of us, including mental health professionals. So that brings us to the two domains which go sequentially, but which are very much informed by each other. That is risk assessment and risk formulation. So these are two separate activities which feed into each other. So first, obviously, you do a risk assessment, and then that feeds into a risk formulation, where you try and assess the level of risk based on the information you have in the SRA. So what is the SRA? So it is basically a process by which you gather data about observable and reported symptoms, behaviors, and historical factors presented by a patient. So you might want to gather data from multiple sources about these domains. It's ascertained primarily by way of a one-to-one psychiatric interview with the patient, but you also may want to, as I said, collect information from various sources, including the key informants, the medical records, and other things. So that is the collateral information. You also may want to supplement your assessment using screening tools. So I have a couple of slides on the merits and demerits of using screening tools in SRA. We'll come to that. So this is about, in a nutshell, what is risk assessment, and then what is risk formulation. So now you have done a risk assessment, and now it's time to form a judgment about the patient's foreseeable risk of suicidal behavior. So based on the information that you collected in the risk assessment, now you want to form a judgment. Is it a low risk? Is it a medium risk? Or is it a high risk? Or imminent risk? Or whatever it is. So it is not exactly a prediction, but it is more a foreseeability. So this word prediction is not really encouraged in when we talk about suicide risk assessment and formulation, because of the various perils of prediction and the various fallacies that are inherent in the process. So the current standard of care is to assess the foreseeable risk based on the picture you have today. And risk formulation is obviously based on, predicated upon the data that you collect in the preceding process of SRA. And it is actually this risk formulation that you use to communicate your the summary results of the risk assessment to other clinicians, and which will assist your triaging and management decisions. Because obviously, somebody who's at low risk, will require a less intensive process of care compared to somebody who's at a higher level of risk or imminent risk. So there you may require more intensive interventions. So it is not my intention to get into management as such today. So this webinar is mostly about how you assess and how you formulate risk and what is the structured process to follow. Management is not going to be discussed today. So there are a lot of resources where you can look it up, or maybe we can do it sometime later. So to summarize whatever we have talked till now, the direction in which you assess and formulate risk is, first you do a risk assessment, and then you do what is called a risk formulation, and then that leads on to the triaging and management decisions. So here, I'll be happy if some of you can just unmute and let me know what you think about this. So we have a lot of rating scales, isn't it, for suicide risk assessment? I'm sure you all know many rating scales for assessing different domains of suicide risk. So for suicide ideation, do you know any scale which are available to assess suicide ideation? Can someone unmute and speak?
Sad persons.
Okay, the sad persons is a more global measure of suicide risk. But any specific scale for suicidal ideation?
Beck's suicide intent scale.
Okay, that is for suicide intent. Beck's suicide
Beck's
intent
suicide
scale,
ideation scale.
yes. There is something called Beck's scale for suicide ideation. So ideation and intent are two different constructs. Intent, I'll be definitely discussing more about it, and also ideation. So ideation is where, somebody has the idea that they have to serve as the agent for their own death. Whereas intent is the degree or the seriousness of the wish to die. Very simply put, that is the distinction. So as you have rightly said, suicidal ideation can be assessed by Beck scale for suicidal ideation. Not only this, there are various other scales, but for want of time, we're just discussing one or two scales in each domain. Then obviously, when you're doing a risk assessment, you also want to assess depressive symptoms. So what are the scales that are available, or what do you commonly use for assessing depressive symptoms for a person with suicide risk?
HAM-D.
You can use, yes, you can use HAM-D. You can use the Beck depression inventory. You can use the PHQ-9. So like that, there are so many tools that are available for depressive symptoms. Very nice. Hopelessness is a very important construct that is given a lot of importance in suicide risk assessment. And many studies have also told that it's an important predictor of eventual death by suicide among a high-risk group of individuals. So do you know of any scales to assess hopelessness?
Beck's.
Yes, there is the Beck hopelessness scale. Very good, thank you. And then thoughts about the future. So we want to always assess, how a person is oriented towards the future when you think about suicide risk, because always you get a patient, probably you get post-attempt or post-ideation, but you're always worried about preventing a future attempt. So you want to assess the kind of thoughts that the patient is having about the future. So do you know any scale for that?
Columbia suicide severity scale.
Okay, Columbia suicide. Yes.
Suicide intent scale.
Suicide intent scale. Okay. So there is something also called the suicide cognition scale, where you are assessing more specific cognitions related to the suicide, particularly in the present and the future. So this is just to give you some more flavor of what all scales are available. You don't have to use all this when you're doing a risk assessment, but this is just to tell you that all these scales are available for various domains. And then to assess history of suicide-related behaviors, there is the self-harm behavior questionnaire, or the suicide behavior questionnaire, or the Columbia suicide severity, rating scale, CSSRS, we call it. So all of them assess lifetime suicidal behavior, because this is very important to assess, because as I will be telling repeatedly during the course of my presentation, if someone asks you which is the single biggest predictor of eventual death by suicide, it is past history of suicide. So I know there are lots of risk factors in suicide literature, in empiric literature, which has been found and repeated. But probably the one that tops the list is past history of suicide. So if there is a past history of suicide, that should immediately be a red flag sign for you to think about something called a chronic risk of suicide. So we'll be discussing about chronic and acute risk also later. So by the way, I will just at this point, and I also request the organizers to give me a kind of a reminder when I have 5 minutes left on the clock, so that I can wind up. Okay. And then protective factors. That is also any scale do you know for protective factors? So when we say protective factors, these are designed to bring down the level of risk. So do you know any protective factors? Any scale for that? Okay, no problem. There is something called the reasons for living inventory, which is something that probably you should be you can also think about using it, and it will help you to give to get a list of protective factors, which also need to be focused upon when you do a risk assessment and formulation. Along with the risk factors, you must also focus on the protective factors. Now, issues with the use of rating scales. Now, we already discussed that there are a lot of rating scales that are available. But what are the possible issues with the use of rating scales? So I would like to point out three major issues with the use of rating scales. That is, they have limited predictive validity. This is probably a very important limitation of the use of rating scales. So, we should not think that we have used a rating scale and we have got, for example, a sad person score of 2 or 3, and therefore, that's the end of the story. No, there could be many limitations in using rating scales, and unless you are Alexander the Crystal Seer, you can not do very good predictions only with the use of rating scales. So that is many studies are available in literature that show that people who obtain a high score, they have less. I mean, they do not have as much expected rates of suicide follow-up, and similarly, those who obtain low scores on rating scales at baseline assessment, many of them went on to die by suicide later. So that kind of a mismatch is very much quoted in literature. And the other important limitation is that, rating scales are not individualized. I'll give you an example. Say, for example, somebody obtains a HAM-D rating of 14. Another person obtains a HAM-D rating of 8. Now, the contextual meaning of 8 for one individual and 14 for another individual may be very different. And remember, suicide is too complex a phenomenon to be reduced to mere numbers on a rating scale. So you don't get the whole picture when you talk about only numbers. And this is perhaps the last, but for me, this is the most important limitation, the most sinister issue that can come with the use of rating scales. That is, it imbues the clinician who's using it with a false sense of confidence. So, for example, even at various points of time when I was beginning off, I have also done this, that if somebody obtained a low score on a particular rating scale that I was using, then I would lower my guard and lower the intensity of intervention. And then I find that my rating scale was incorrect. And then, before problems could set in, we had to correct ourselves. So the use of rating scales can actually give you a false sense of confidence if the scores are very low. And we all know that in various instances, especially individuals who have a high degree of intent, they tend to conceal many aspects of their ideation, and they don't reveal everything. And that kind of gives a false sense of confidence to the treating team. So that is the possible issue with the use of rating scale. So what is the key message that we should take away from this segment of the discussion? That is, although self-report measures are often used as screening tools, an adequate evaluation of suicidality should include both interviewer-administered, a more of a semi-structured interview or an unstructured interview, and also supplemented with some self-report measures. That will be the best approach to take, rather than focusing only on a scale or a self-report measure. That is not going to be helpful. That is not the direction in which current evidence supports suicide risk assessment and formulation. That is only the use of a tool. So what are the various elements of a suicide risk assessment? So this is the most important part of the presentation. And if you forget everything else, just remember this one slide at least from this presentation. That is risk factors, protective factors, specific suicidal inquiry, and evidence-based warning signs. So we'll discuss all of these in some detail, but again, I'll just go through these 4 major domains of risk assessment. That is risk factors, protective factors, specific suicidal inquiry, and evidence-based warning signs. So we'll discuss each of these in some detail. So what are risk factors? So risk factors are basically those factors which, when present, increase the likelihood of suicidal self-directed violence. Very simple. So now risk factors are of many types, and we need to document whatever risk factors we elicit under these 3 headings. So what are the 3 headings? The first is static or stable risk factors. Now, I think this is something which all of you can easily understand. I don't need to explain, these are age, gender, marital status, family history, personality, and past history suicide. Past history suicide I have put in red because that's obviously the most important static or stable risk factor. Now, why I have called this a static or stable risk factor? See, you cannot change a person's age. You cannot change somebody's gender. You can't do that. So, but these are perhaps of limited significance when dealing with one individual. But where do these then become useful? these factors become useful when you want to identify a high risk group from a population. So from a population, if you want to ask from the population of Pondicherry or Tamil Nadu who are at higher risk of suicide, you can go with these kind of a demographic indicators. But otherwise, in an individual given patient, when you're trying to do a risk assessment and formulation, obviously these factors have limited role. Dynamic risk factors are more important for us when we deal with an individual case. And what are these dynamic risk factors? These are things which you typically elicit in a mental status examination, like suicide ideation, the intent. I already explained these terms before. Hopelessness, which is a very distorted negative view about the future. And then active psychotic symptoms, particularly things like command hallucinations and all, which are associated with a high risk of suicide, and substance use, psychosocial stress, and the like. So all these, as you can see, these are mostly factors which we will elicit during our MSc, but these are important to document under these headings. So dynamic risk factors. And another very important thing which we often overlook in risk assessment is future or anticipated risk factors. Now, this is something that we always keep telling the residents, you don't only look at the static and dynamic risk factors, but also what are the future risk factors. And in my case vignette at the end, I have actually included something on a future risk factors to drive home this point further. So, for example, things like planned discharge. You are making a change in the locus of care. Obviously, it has been shown that a change in the locus of care is associated with an elevated risk of suicide for a finite time period at least. Any future stress, for example, is any marriage or something planned in the future, or is any other, mortgage or any other event going to come up in the future. So these are important also to document, because then you know that whatever high risk precautions or other, support mechanisms that you have mobilized to keep a watch over the patient or to support the patient during this high risk period must continue till that future stressful period or anticipated stressful period is tided over. That is the importance of eliciting this and documenting this. And then access to method of suicide. For example, when you discharge a patient, is he or she going to go back to their house and have access to pesticide? Then that also would put the patient at an elevated risk of carrying out the action. Many a times, by the time the patient is discharged, we are not able to completely, go for a remission of whatever condition we intended to treat. So still there will be some residual symptoms, as you know. So, and when a change in locus of care is associated with increased risk, coupled with increased access to method of suicide, that can probably tip the patient to, doing the suicidal behavior. So under these three headings, you have to document the risk factors. And then protective factors. At this point, can someone unmute and tell me what you think are the possible protective factors, particularly in our setting?
Good family and social support.
Very good, excellent. Good family and social support. Anything else?
Number of children, large number of children have increasing protective factor.
Okay,
And,
even having one child itself is also a protective factor. Okay, fine.
And
Okay.
holding strong religious beliefs.
Okay,
and,
holding strong religious beliefs.
And where there is restriction of guns or drugs like that.
Okay. No. Yeah, I agree with you. Where there is, possession of a gun is like access to means and a method of suicide will increase the risk. But here we are talking about factors that per se, if they are present, they increase the, they decrease the level of. So you're very correct. Whatever you have told in the first 3 points are correct. Thank you so much. So these are all the evidence-based protective factors in suicide literature, that is having a robust social support mechanism and a robust therapeutic relationship. So don't underestimate the relationship that you as a therapist share with the client. That is also the quality of that relationship also has a protective factor on eventual likelihood of suicide. Then somebody who has good coping skills is definitely going to be at lesser risk of suicide. Particularly in the case of women, more than men, being pregnant or having children are a good protective factor. As you have rightly pointed out. A sense of overall, I'm sorry, there's some disturbance. Can everyone be muted? Yeah, thank you so much. So a sense of overall life satisfaction, somebody who has that kind of a perception about their life, that's a protective factor which you can build upon. And then somebody who has reasons for living, somebody who tells you that, yes, I have a reason to live because of 1, 2, 3. Somebody who tells that is also a good factor. So see, once you elicit all this, the importance is, along with focusing on reducing the risk factors, you must also focus on boosting the protective factors when you're trying to take a balanced approach to suicide prevention. So you want to try and ask the patient to focus on reasons for living, or the fact that they have children and all, when you try and formulate a management plan for their suicide, or what we call safety planning. So how to elicit protective factors? So I want you again to unmute and tell me some sample statements that you can ask in order to elicit protective factors from an individual. Now, why am I asking you to tell me the questions? Because of two reasons. One is, all of us face difficulties in framing the right words when we ask patients about sensitive issues such as suicide. And secondly, there is enough and more evidence in literature to suggest that the way a question is framed has a great deal to do with the kind of responses you elicit and the degree of honesty in the responses that you elicit. So because we all want accurate and honest answers when we are dealing with suicidal clients, because it is entirely based on the information that they give that you're going to formulate the management plan. So we need to frame our questions as accurately and as empathically as possible. So can you try and unmute and tell me some sample questions to elicit protective factors, and then I will show what I have prepared.
Sir, do you think whether there are any reasons for living your life? Or
okay, do you think there are any reasons for living? Okay.
Do you think what will be your family status after your attempt?
Okay, do you think what do you think will happen to your family members after you die or after you attempt suicide? Okay. Anything else? Anyone else wants to unmute and speak?
Kids. How many kids
What
do you
makes you
have?
go on?
Yeah, how many children do you have? Okay, and somebody was saying something else, sir.
How
What
they
makes you
handle
go
their
on in life?
What makes you go on in life, isn't it?
Yes.
Yes, very correct. Absolutely correct. Someone else also wanted to say something.
how they've handled their stressful states previously, sir.
Okay, okay. So you want to ask about how they have handled stressful states previously so that you can build on those strategies. Okay, excellent. So thank you so much for all the responses.
What dreams and
so-
aspirations you might have had before
Yes,
the
exactly.
attempt?
Yes. What are the dreams and aspirations that kept you going, during the times prior to contemplation of suicide? So very simple questions can be used to elicit protective factors. What keeps you going during these difficult times? So somebody has come to you with suicide or a suicidal idea, you can always ask this question to get them beginning to talk about their reasons for living. Or you can openly ask them, what are your reasons for living? So take their focus away from the suicide to something like a focus for reasons for living. So that's also the aim of these questions. So these are some simple questions you can ask. And I'll be sharing one article. I'll try to share an article which I've written on this topic. So where I have given more examples. Obviously, we're not able to discuss everything due to paucity of time. Then specific suicidal inquiry is another very important domain of SRA. And when we talk about specific suicidal inquiry, what do we mean? So it means we are trying to elicit ideation, plan, intent, and behavior. So these are the 4 areas that we need to assess in specific suicidal inquiry: ideation, plan, intent, and behaviors. I'm sure you all know what these terms mean. Ideation means the idea of serving as the agent for one's own death. So in ideation, you have to remember the mnemonic FIDS. These are the 4 areas to assess: frequency, intensity, duration, and specificity. The specificity is what comes as plan, intent, and all. So that I'll be discussing subsequently. And it's also important to assess the degree of suicidal ideation severity in the last 48 hours. Now, because this last 48-hour period, prior to meeting you or meeting any health professional for that matter, or landing up in the ER for that matter, those who have a higher intensity of suicidal thoughts in the last 48 hours are always at a higher degree of risk for attempting or dying by suicide over the next few days or the short term. So that's why the last 48 hours is something that you have to always specifically ask for. And then plan. So whether it is a non-specific ideation or whether the ideation has crystallized into a plan, that is what we call now the ideation is becoming more specific. So this is called specific suicidal ideation. So whether it's a plan, that is whether it has translated into a time frame to carry out the plan, whether there is available means, what's the lethality of those means, and what is the availability of the means. So somebody who has, a lot of a good quantity of pesticide or something that's stocked at home, and who also has a chronic background suicidal ideation is going to be at a higher risk because they have easily accessible means. So one of the things that we always focus on in management is cutting off the means. And then behavior. So behavior, you look at past attempts, aborted attempts, rehearsal behaviors, something like how they are rehearsing to carry out. So for example, they visit a number of bridges and then decide from which one to jump off and things like that. And then there is NSSI, or what we call non-suicidal self-injurious behaviors, which by definition, there is no intention to die by suicide, but literature has shown that individuals who engage repeatedly in NSSI behaviors eventually are at a higher risk of dying by suicide. So that's why it's also important to ask about NSSI behaviors in specific suicidal inquiry. And then finally, perhaps the most important is always to ask about intent. That is, what is intent? It is the extent to which an individual expects to carry out the plan or whatever suicidal plan they have, and believes that the plan or act that he or she is going to carry out is going to be lethal. So that to what extent they think that it will end, the act will culminate in ending their life. That is also something that you have to ask. And somebody who has a higher degree of suicide intent on a simple scale like a Beck suicide intent scale or any other scale that you use is going to be at a higher risk of dying by suicide than somebody who has a low intent. So now I want somebody to unmute and tell me how to elicit ideation, plan, or intent. What are the questions you can ask to elicit ideation, plan, intent? Any of these components you can unmute and speak.
Have you had thoughts of harming yourself?
Very good. That's a very simple, a very elegant initial question to ask with. Have you had any thoughts about harming yourself? Okay. If they say yes, how would you proceed further? Can anyone else add on to this?
Have you tried any other methods, or this is the only method you have tried?
Have you tried any other methods to end your life, or is this the only method? Okay. Okay. Anything else?
Have you ever
Have
you
attempted
thought
to
about
harm
how
yourself?
you are going to commit suicide?
Have you ever thought about which method or how you are going to did you say commit suicide? Okay. Now, better word is die by suicide, because somehow, in suicide literature, if this word commit is discouraged, because now terminology is given a lot of emphasis when you are doing, you have to use appropriate sensitive terminology. So one of the terminology that is slowly being phased out now is committing suicide. So better word to do is die by suicide. Okay. So yes, these are all possible questions you can ask. Any question for intent or plan specifically?
What do you
previous
think?
attempts?
What do
Yes.
you think the reason for killing yourself? Whether you want to solve the problem as such, or whether you want to end the life as such, like that.
Okay, so here you are trying to clarify between a suicide or a non-suicidal behavior, because
Yes.
in a suicide, when we label something as a suicide attempt or a suicidal behavior, there should always be an intent to kill oneself. So that is very important. Otherwise, we are talking about NSSI, that is non-suicidal self-injurious behavior, where the intention is not to end one's life, but the intention may be anything else, maybe n number of things other than ending one's life. So that is a key distinction to make. Okay. Any final, one more, we can take one more response before we move.
Sir, how did the other family members get to know whether did the patient himself went and told them that he has attempted for a suicide, or
Yes. Yes.
did they encounter on their own?
Yes, very true, madam. So what you're trying to say is how you will elicit intent, through by asking the family members about how they discovered the attempt and all. Okay, so I am going to show some questions which you can directly ask the patient, and you will see that I am going to present 3 or 4 questions, and as we progress along these questions, it is going to move from ideation to plan to intent. So this is a very important question that you can open with. Sometimes when people feel the way you do right now, they start to have thoughts about suicide. Has this ever happened to you? See, this question is very useful for individuals who have not yet communicated their ideation to you. So, but you want to broach the topic, and you want to broach the topic using what is called the normalization technique. So this is called the normalization technique, because you are not putting them in any difficult situation. You're not telling them that, oh, otherwise the patient may feel, oh, why should I reveal my ideation to this doctor, because he may judge me, or he may, think about something else. He may even admit me or something like that. So what you're trying to say through this question to the individual is that it's okay to have thoughts about suicide. Many people who are having difficulties like you do also have similar thoughts, but has this ever happened to you? So what the individual feels? Okay, the individual feels, okay, here is a doctor who's prepared to understand the degree of distress I'm going through, and therefore let me be more honest and let me communicate my thoughts to this person, because he seems to be understanding. So this way you're more likely to elicit a very honest response. And once you have elicited an ideation, then you really want to move towards asking whether it's a very non-specific ideation or whether it has translated into a plan and intent, isn't it? So then you ask a very open question about what kind of thoughts have you been having? You said you're having some thoughts about suicide, but I would like to know more about that. What kind of thoughts have you been having? And then if he says something about that, then you move forward and ask, okay, do you have a plan? Have you thought about any particular plan or any methods to kill yourself? Have you contemplated about this at any point of time? And then if the patient says yes to this too, then you really want to ask the question about intent, that is in the next 24 to 48 hours on a scale of 1 to 10. How likely is it that you will act on your plan? So somebody who scores at 7 or 8 versus somebody who scores at 2 or 3, then you can begin asking them, why did you give yourself a score of 7 or 8 and not 3 or 4? And that way, or if somebody gives a score of 3 or 4, you ask, why not a 7 or 8? That way, you try to elicit maximum information, why this way and why not that way. You get a whole lot of information on risk and protective factors that is really going to inform your risk formulation and management. So these are some questions I think that you can keep in mind. And then I really come to the last part of the, we have finished risk factors, we finished protective factors, we finished specific suicidal inquiry, and now we come to evidence-based warning signs. So in the fall of 2003, the American Association of Suicidology convened a meeting of the American Association of Suicidology in the fall of 2003 convened a congress of leading voices in the field of suicide research to come together, deliberate, and then arrive at a consensus on proximal indicators of suicide risk. See, till that time, what we had was a whole lot of literature and evidence on risk factors. Now, what is the difference between risk factors and warning signs? It is something like the difference between the traffic yellow signal and the red signal. We all know the difference between yellow signal and red signal, isn't it? So the risk factors is something like the yellow signal. They tell you to apply the brake, but you still have some time. You can still wait. But a red signal is a red signal. You have to immediately stop and act because it indicates imminent risk. So that kind of an information about the imminent nature of suicide risk was not really provided by the evidence-based risk factors that we had till that time. So this is when a lot of researchers came together and tried to form a consensus on what are the warning signs that indicate near-term risk of suicide. And then the group's work was later abbreviated into a very catchy acronym that I'm going to present here, and which I think many of you may already be familiar with. So I'm going to present each of the alphabets one by one, and then together it will read as the mnemonic. So first is I, that is ideation, which may be threatened or communicated. So if there is suicidal ideation, which is openly communicated or what we call threatened, not openly communicated, but deciphered through the actions of the individual, then that is a warning sign. S for excessive substance use, especially recent increase in patterns of drinking or other substance use. P P for purposeless or purposelessness, that is, there is no reason for living. A for anxiety, agitation, or insomnia. T for feeling trapped, or what they call entrapment, where they see no way out of their current problem other than death by suicide. H for hopelessness, and W for withdrawal from friends or family or society. So that is especially a very recent withdrawal, which is a marked contrast to the individual's prior behavior. And then A for anger or rage, and R for recklessness. It is excessively risky acts like driving under the influence of alcohol, again, which represents a clear change from the previous behavior, and very dramatic mood changes. So now we can begin to see what is my mnemonic here, isn't it? It is called is, path, war. So that is the mnemonic for the warning signs, evidence-based warning signs in suicide research. So even if one warning sign from this is present, it means that there is imminent risk and you have to probably intensify your level of management. Now we come to the last part of the presentation, that we have finished everything about suicide risk assessment. We have seen the 4 domains, and now we go to suicide risk formulation models. So again, I'm going to just discuss 2 models of risk formulation. Here, the first one I'm going to discuss is called recognizing and responding to suicide risk. So this is the recognizing and responding to suicide risk model, or the RRSR model of risk formulation by the American Association of Suicidology. It was published in Suicide and Life-Threatening Behavior in 2014. Quite a popular and widely accepted, and it's also easy to understand model, as I will explain it. So here, suicide risk is conceptualized in 2 planes. One is chronic risk and the other is acute risk. So chronic risk means it is, judged as a yes or no thing. It's more of a, it is something that if present, it implies a lifetime vulnerability to suicide. So at any point of time, the individual could have suicidal thoughts depending on when acute risk factors come and go.
Dr. Vikas Menon, you have got muted. Please unmute.
Doctor, kindly unmute, doctor. It got muted. Ah, yes, doctor.
I'm sorry, but yeah, now my slides also got stuck. Am I audible now?
Yes, doctor.
Yes,
Yes.
sir.
Yes.
Yeah, yeah.
Okay.
Audible, sir.
Just
Yes, doctor.
yeah, I don't think my slides are visible now, no?
Yes, doctor. Your slide's not visible.
Is it visible now?
Yes, doctor. Now visible.
Yes, doctor.
Yeah. Okay. So
Open up the slide share, sir.
yeah. It is in slide share now, isn't it?
It's fine now.
It's okay now?
Yeah,
It's okay. Yeah.
Okay. Yeah. So sorry about that. So as I was discussing, under 2 planes you conceptualize suicide risk, that is chronic risk and acute risk. So chronic risk is a lifetime vulnerability, whereas acute risk is judged by the risk factors and warning signs. And that is what really gives you a picture about the foreseeability of suicide. So it is like a suicide zone. So I'll just explain that through this diagram. So there is this outer ellipse and inner ellipse. The outer ellipse is a chronic risk of suicide, and in which somebody who has a chronic risk, for example, the 2 most important factors which confer chronic risk of suicide according to this model are past history of suicide and family history of suicide. So what that means is someone who has any one of these 2 or more of these risk factors will always be in this outer ellipse. They're always at a chronic risk of suicide. And on top of that, when there is an acute risk or an acute stress, they migrate to the inner ellipse. And then when these acute risk factors are they are stabilized either through your management or through natural course of events, they move away from the acute risk ellipse back to the chronic risk ellipse, but they do not reach a point where the risk is 0. That is what is important to understand. They only go back to the chronic risk. So when you document also, this kind of a distinction has to be made, that the individual continues to remain at chronic risk and only what you have done is mitigation of the acute risk. Now, if you don't do that and the patient unfortunately, does some harm to himself later, it will be viewed as your liability. So this is where the importance of understanding this kind of a dichotomous conceptualization of suicide risk and the documentation comes in. So recognizing and responding to suicide risk model has another assumption. Apart from this two-plane assumption of suicide risk, the other thing is that in an individual who carries a greater number of warning signs, like the boy with the blue jacket, compared to the boy in red, who has only 2 warning signs, somebody who has a greater proportion of warning signs is at a greater degree of risk compared to somebody who is at a lower level of risk. So this is another implicit assumption in this model. The other model that I'm going to just present here in a single slide is the Rudd model. And with that, we'll probably wind up and then we'll go to the case vignette. So the Rudd et al. Model is another very important model of risk formulation, which is based upon the fluid vulnerability theory of suicide. So it's okay if you don't not able to remember these names, but what is again here important to understand is a lot of similarity between this model and what we just now discussed, in the sense that chronic risk again is viewed in this model as a dichotomous construct. It's either yes or no. And then you have acute risk, which is conceptualized on a 5-point continuum. That is minimal risk, mild risk, moderate risk, severe risk, and extreme risk. In minimal risk, there is no ideation. In mild risk, there is non-specific ideation. That is, it is not yet translated into a plan or intent and things like that. Moderate risk is where there is a specific suicidal ideation with a plan. And once there is emergence of intent, it is severe risk. If it is only objective intent, that is, the person does not subjectively tell you that there is an intention to die, but you can infer it. They may be writing a will, they may be giving away their belongings, which they never used to do previously. So all these are objective telltale signs that something is in the offing. So that is severe risk. And then extreme risk, where there is where there is openly expressed subjective intent to die. So that is the acute risk, conceptualized on a 5-point continuum, and chronic risk, which is dichotomous. So this is my last slide, that is operationalizing low versus medium versus high risk. So this is not something that you'll find in the books, but this is something which I have formulated based on my experience and some of the articles which I have published. So in low risk, so you can conceptualize, this is how you make an assessment or a judgment about the level of risk after you have completed the SRA and the SRF. So finally, you want to label the category of risk and then carry out the management based on that plan. So what do you mean by low risk? Low risk is when there is only suicidal thoughts. Medium risk is when there are thoughts and there is also a plan and there is means that can be easily accessed. And high risk is when all this is there, plus there is also a time frame that the individual intends to carry out the plan within the next 48 hours usually. So that is also called high risk, or you can also call it imminent risk. So we try and categorize according to these 3 categories. So are we ready now for the case vignette? Chairperson, do I have another 5 minutes?
Yes, sir. Yes, sir.
Yes, we can go.
You can proceed.
Yeah, okay. Okay, so with this case vignette, I'll wind up, and I hope to have some participation from all of you. So I'll be showing you a case vignette. The slides will be a little crowded because I'm trying to put everything together in a slide or 2, And then what I want you to do is take a minute to read this case. And I have another second part of it coming up in the next slide. But in this slide, I want to tell you, or I want to ask you to tell me what are the important domains that you think are pointing towards suicide. And then finally, we'll see whether it's a low, medium, or high risk of suicide. So remember, please go in the approach that we discussed. That is, first look at whether there are any chronic risk factors like past history of suicide or family history of suicide, whether there are any acute risk factors, all those dynamic risk factors that we discussed, which you elicit in the mental status examination, whether there are any future or anticipated risk factors, whether there are any protective factors, and whether there are any evidence-based warning signs. So under these 5 domains, I'll repeat: chronic risk factors, dynamic risk factors, future or anticipated risk factors, evidence-based warning signs, and protective factors. So under these 5 domains, if you can tell me what you are in this order, then it will be a very structured approach which we can try and apply to our future patients also. So first, starting with chronic risk factors, does anyone see any chronic risk factor in this description?
He fears demotion, so it might be a chronic risk factor.
Okay, so he fears demotion, it might be a chronic risk factor. Apart from that, actually, there are no other chronic risk factors here. So fine.
He has an at-risk behavior, sir.
Yes, sir. Yes, madam. He has an at-risk behavior. So that is my second part. So what are the dynamic risk factors that you have been able to notice in this case description? Can you unmute and speak?
Hopelessness
Hopelessness. Okay.
and psychosocial stress from his job.
Psychosocial
The
stress on his
organization,
job.
And
yeah, they're not supporting him in his secretary's claim.
So the organization is not being very supportive. So that you think is a
And the
dynamic risk factor.
reason for
Fine.
audit. Yes, sir.
Okay. Anything else? Any other dynamic risk factors? There's a whole lot of them
he
actually
has
here.
anxiety and depressive symptoms at present.
Very good, very good. So depression is there, anxiety is there. These are definitely dynamic because these are amenable to intervention. That's what we mean when we say dynamic. You know, you can actually engaging him in some program or psychosocial program or pharmacological program and try to bring down. So those are dynamic. So depression, anxiety, somebody said hopelessness. Anything else?
He's
There's
withdrawn.
also, yes, withdrawal. Yes, withdrawal is actually, where does it come? Does it come under the dynamic risk factors or does it come under warning signs?
Evidence-based warning.
Yes, and in the ISPAT warm signs, it comes no withdrawal from friends and supporters. So that should come as an evidence-based warning sign. So importantly, one reason why I put this is, are you able to elicit any future or anticipated risk factor? I've given a clue there in the case.
He has
Upcoming audit.
Exactly. So there is an upcoming audit of his bank ledger where he is likely to be incriminated because he has done something wrong. Okay. So what does that tell you? As I told before, whatever management plan you're preparing, that high risk period needs to be continued till that audit is over. Okay. So I am very thankful to you for bringing out the important points of the slide. I will now summarize it. So all the things which I've highlighted in blue are all dynamic risk factors in this case. Depression, anxiety, increasing level of panic, insomnia, problems with attention, hopelessness, and things like that. And then what I have put in the yellow is the future or anticipated risk factor. So that is something which you have rightly pointed out. And then the two things which I have highlighted in red, these are among the ISPAT warm signs. That is a sense of rage or anger and withdrawal from friends and supporters. I hope this is clear. And is there any questions on this? Or maybe we can take questions at the end also. I'll now proceed with the rest of the case vignette. So this is the last slide of the case vignette. Maybe you can even take a few seconds to read this and then go in the same order. Now tell me chronic, dynamic, any future or anticipated, evidence-based warning signs, and protective factors. So first, do you see any chronic risk factor here?
Family history of
suicide.
Family history of suicide is there, and
Diabetes, he has had cardiovascular problems chronically.
okay, so having
And,
medical issues may
substance
also be
use.
there.
Substance use is there.
Substance use.
Okay, so substance use is actually, where does it come? It also comes under the evidence-based warning signs because he has recently increased the frequency and amount of his drinking, and we discussed that in his part one. S stands for excessive substance use. So yes, you are right, but it can be categorized under evidence-based warning signs.
And
So
the
here,
past history of suicide attempt is there.
exactly. So that is the two most important things that are chronic, that puts the patient at a chronic risk here. That is past suicide and family history of suicide. Very correct. Now, what are the dynamic risk factors which you have been able to elicit here? Any dynamic risk factors?
Substance use.
Suicidal ideation is having.
Suicidal ideation is having.
And
So ideation is a
substance-
threat.
Pesticide
Substance use is
availability.
there.
Yeah. So dynamic risk factors are the unknown. He has the availability of means is there, and that is something which you can modify by your intervention. So that's pretty much a dynamic risk factor. And then there are warning signs which like suicidal ideation and increase both the frequency and amount of his drinking. See, whether you put this under risk factors or whether you put it under warning signs is perfectly fine, but you should not miss this. That is what is important. So because in anyway in ISPAT warm signs, the ideation and the withdrawal are coming and the substance use are coming. That's why I put it under red. That is the warning signs. But if you want to put it under risk factor, there is absolutely nothing wrong. It's not the head under which you classify that is important, but you go in this order, you are more likely to, get all the bases covered and not miss any important thing. So now, actually, when we do the workshop, we give time to participants to formulate the risk and write, but this being a webinar, we will not spend time on that. So I have given you the ready-made formulation for this case. You can take a few seconds to read this, It kind of brings in everything that we discussed earlier and summarizes the suicide risk in a narrative summary form, which you can use to communicate with clinicians or guide your triaging and management decisions. So this patient will be at a medium-term risk of suicide in the near term, and that is at least until the audit is accomplished and his fears are not realized. So that's what it means. So that kind of a risk approach and all the management has to be continued till the audit is over. And you would say it could be OP care also for this patient, but provided that there is a high degree of supervision and you're able to get reliable attenders. Otherwise, I would admit this case and manage till I am confident that the risk levels have gone down. So if you have taken time to read this, and I will now conclude here by saying that, we have discussed about risk assessment, which is the main procedure used by clinicians to determine whether an individual may be at risk of suicidal behaviors. The purpose of the SRA is to identify risk and protective factors that then provide data for formulating risk. And we have discussed the major elements of an SRA, which is the most important thing I want you to carry home from today's presentation. That is risk factors, protective factors, specific suicidal inquiry, and evidence-based proximal warning signs. And we have also discussed how to stratify a patient's level of risk through an SRF. And the important thing is, see, this is not a one-time event. Once you do this risk assessment, for how long does this have validity? Typically not more than 48 to 72 hours, particularly in high-risk patients, because things are very dynamic, A lot of new information comes in the next day, and a lot of dynamic nature. It's a very fluid thing. That's the basis of the fluid vulnerability theory of suicide. So best to repeat this process till you feel confident that the risk levels have gone down. That's all. I'll stop here. I thank you very much for a patient listening, and more importantly for an active participation. And I'll now hand over back to the chairperson. I am happy to take any questions.
Thank you, Dr. Vikas Menon. It's so fantastic to hear from you. And it's so crystal clear, and you communicated so effectively with all the audience. And you focused on specifically on certain aspects, especially on the suicidal inquiry, which every clinician need to know. We just open up the topic, no? Those are all very important for the beginners. You specifically touched upon those points. I think your topic is not like a lecture. It's more like a application-oriented, dynamic, interactive lecture, I would say. Thanks to the organizers. I hand over the mic to organizers.
Yes, sir. Sir, thank you, sir. Thank you, Vikas, sir, for your wonderful presentation, sir. It's more than presentation, is a kind of a lively workshop for all the residents and consultants with me here. Thank you, sir. Regarding the winners for the questions, so we specifically asked some questions displayed in the slide, but unlikely here we made every question as a discussion. So I am selecting the winners in the context of the people who are participating in the discussion very actively. So in that context, I am selecting 4 people, sir. One is Kaushik, second is Shamini, third is Kalesh Selvi, and fourth, I'm not knowing her name. It's shown as Samsung AM. So I think I request her to post her name in the chat box. So we will select these 4 people for the prize, sir. And now the session is open for the questions, sir. People can unmute and ask, or they can type in the chat box. Till then, sir, any comments from Panir sir, Sivasalam sir, Ramarajam sir?
Yeah, because it's an excellent and wonderful presentation. Really very useful for the postgraduates, also practicing psychiatrists. We learn many things from you. Because of Snega Hospital, we also have recently started a Snega Hospital suicide prevention center in our hospital. We are nowadays, after this college, the Kallakurchi incidents, we are focusing some of the schools. We are going, our team is planning to go to the school. We are talking about the children's and also school teachers, sensitize the school teachers and the parents, how to identify the risk and when they have to approach the medical profession. It's a very good presentation, Vikas.
Another thing, sir, we are also conducting a yearly one-day workshop in the context of psychological first aid for the community people and all, sir. So lastly we have conducted, and this year also we are planning to conduct as a certificate program, sir, 1-day workshop.
That's fantastic.
Yes, sir. Panneerselvam, sir, you mentioned a point. After this Kallakurichi incident, I had come across 3 patients with a suicidal behavior. One completed from jumping, another one jumped but subsequently rescued. Another one was he was treated with effectively with medicines. I think once it happens, and the copycat suicides are happening frequently. So I think this is gaining more importance nowadays.
Yes, sir, exactly. So now we have one question in the chat box, sir. Yeah, so then, the question is more evolutionary than biological, I think. So why human beings alone have the tendency to commit suicide or have suicidal ideations? So your point is on that, sir.
Yeah. So it is a difficult question to answer, but I think, you know, one of the things which I learned is that there is something called theory of mind. So that is I think many of us will be familiar with this particular theory. So it's the ability to ascribe mental states to individuals. And that is something which is a uniquely human quality. So, you know, we as human beings, we have this ability to ascribe mental states to others, to what he or she is thinking about me and what he or she is thinking about another. We talk about first order and second order theory of mind approaches. So a lot of these things which are uniquely human capabilities also drive us into despair and, you know, the ability, you know, all putting together all these, juggling all these things together and living in a conflicted world. So these are uniquely human traits. And then many of us reach a point where, you know, we have a biopsychosocial vulnerability to suicide, and then we are not able to make sense of our experiences. And then we look at what they say is, you know, suicide becomes the only way out of your present predicament. That is what drives individuals towards suicide. But it's never a single cause. That is what is important to understand. Suicide is always multifactorial. And so this question gets repeatedly asked: why do some individuals do while some individuals do not do? So it's always a multi-factor hit hypothesis. And what we are seeing as the proximal risk factor maybe only be the final nail in the coffin. This is my answer, but I'm sure there are many more learned people in this panel who are much more experienced and will be able to offer different insights. So maybe others can also pitch in.
Okay. And the second question, sir. This is about assessment of suicidality in adolescent. And they have given an example of gaming disorder in children who are vulnerable for committing suicide or developing suicidal ideation. So in that context, it's assessment of suicidality in adolescence, sir. So your point is, sir.
I think this is a very important question and something which has been asked in many of the previous workshops I conducted on this topic. Because see, what I presented is a broad model, and the general principles, whatever we talked here, it is the same approach that we use for adolescents. But in adolescents, obviously, there are 1 or 2 special issues that come in. First one is they always like to keep things confidential, especially, you know, when we are dealing with, I think we are all dealing with adolescent people who come with a mental health crisis, suicidal crisis. So they don't want to reveal many details and they're very guarded about it, as you rightly pointed out. So this is where the normalization approach is very helpful, or what we call the validation approach. You know, what I presented, that is, don't put them in a position where they feel uncomfortable telling you their deepest secrets. On the other hand, start with a very normalized. So what I use is, so see, many people who are going through the difficulties that you are facing now, many of them have thoughts about suicide or contemplate about suicide. Has such thoughts ever occurred to you? So this is a question that I use in order to put them at ease, so that, you know, they don't feel that, you know, I don't directly ask about suicide. So first of all, we don't directly go to this topic. We begin by asking them some general questions about their current difficulties that they're going through, and then reach the topic about suicide in a very normalizing, validated manner. And then if they do express concerns about confidentiality, I think once we have reached a sufficient degree of rapport, I think we need to tell them that, you know, your safety is most important. So always safety concerns override confidentiality. So that's very important to know, and that's very important to document. So we get a lot of students, we tell them that it's your safety that we have in mind, and therefore we need to inform your parents. Most of the times we are able to get a buy-in from there. If not parents, they will at least tell somebody else, you know, who they are comfortable disclosing it with. So this is an approach that you can use to begin to get them talking about suicide.
Yes, sir. So I have one question, sir. I have one question.
Yes.
So a schizophrenia patient. So he has kind of assaulted or murdered his daughter. This kind of context is common when we see cases. So this kind of people, when they get insight after the improvement with the drugs, so they get to know about what happened in the past and what they did to their children. So in this condition, so I think attaining a remission or a good judgment or insight at the end of the treatment, I think I feel fearsome. So how they will deal with this? So in this condition, I feel they develop suicidal ideation after getting understanding about the incident happened. And this is one part, sir. And the post-psychotic depression and suicidal incidences. So in these two contexts, I want your understanding and pointers.
So you are absolutely correct, Dr. Nurul, when you say that there has been a lot of literature that shows that development of insight, which we all strive to do, through psychoeducation and through various other methods in people with psychotic illnesses, particularly schizophrenia, has been linked to a higher degree of risk of suicide. We all know that 10% of individuals with schizophrenia eventually die by suicide, but those who have developed insight over the course of treatment, they are definitely at a higher risk of dying by suicide, probably because they feel more demoralized. And once they get the insight, then they begin to see how less they have achieved compared to their peers and things like that. So all these things, lack of attainment, lack of achievements and all, drives them to despair, demoralization, and suicide. So that is the first thing. Second question was on core psychotic experiences.
Post-psychotic depression and
yes.
suicidality.
Yes. So post-psychotic depression is also something that we commonly see. And the post-psychotic depression also has been associated with suicidal ideation, but perhaps it's not only the post-psychotic depression. It is also, as you said, it is also linked to development of insight and other variables, which improve in the stabilization phase, or what we call the post-acute phase of treatment, which is also contributing to suicide, not just the post-psychotic depression.
Okay. So when comparing the reactive depression and bipolar depression, sir. So in bipolar depression, they didn't have a single or multiple causative factors for the depression. But in the reactive type or an adjustment disorder type, they do have several factors which is causing them to depress. But we feel we come to know the prevalence of suicidality in mood disorder. The bipolar depression is more than the reactive or secondary depression, sir. So how can we understand this paradigm, sir?
So I think it's a good question. I think it's a good question to think about. That is, basically we can conceptualize this as something endogenous versus reactive depression. So, sometimes we also say, for example, if I have to give an analogy, we say a psychiatric illness with a precipitating factor has a better prognosis than a psychiatric illness without a precipitating factor. We all know this from our basic training and things. So why is that? Probably once we identify a precipitating factor or a life condition which is precipitating a reactive depression, probably we are in a better position to understand the genesis, the evolution, and probably give better management targeted at that factor. Obviously, there is no guarantee that the patient will not develop it in the future, but we have something finite and definitive to work on when we get a precipitating factor. And that way we are able to make a little more progress in terms of tackling the various contributors to the patient's current condition. On the other hand, if it's more of an endogenous thing, or what we call a melancholic thing, which can occur both in unipolar depression and, as you said, some of the bipolar depressions. So in these cases where we do not really know what we need to target, it becomes much more challenging for us to begin to formulate a management plan that is going to really tackle all the biopsychosocial elements. So I would look at it in this way.
Okay.
Mr. Naveen, can you display the names of the winners of the previous?
Yes, sir.
Please display before the crowds goes. Then we'll continue the questions. Nurul, announce the winners.
Yes,
of
sir.
The
Previous, sir.
Yeah, previous two webinar.
Previous winner in the last webinar, when Dr. Thomas was presenting on psychiatry. So there are 5 people, sir. Number 1, Dr. Hardik from Calicut, Dr. Santosh from CMC Vellore, Dr. Swapnil from NIMHANS Bangalore, Dr. Shamini from TVMCH, and Dr. Kalai Selvi from Salem Medical College. These are the 5 people, sir.
Okay, fine.
So we have been handing over the book called The Cognition, written by Dr. S.R. Chandra. So we are in the process of giving to one by one, sir.
Naveen, can you share the certificates?
Yes, sir. I shared, sir, already. 1 second, sir.
No, it's not coming. It's not visible.
Okay, sir. 1 second. So now it is visible, sir?
Yeah, you make a slideshow and
Yes.
all certificates. Read out the names.
Yes,
Already
yes.
has informed. Slideshow.
Yes, sir.
Yeah. You move one by one, roll it.
Yes, sir.
It's not coming.
So now it is coming, sir. One by one is rolling, sir.
Yeah, it's not coming. Okay. It's not coming.
Yes, sir. Yes, sir. Vikas, sir. So, Vikas, sir. Yeah, so it's my last question, sir. So in OCD, we have aggressive obsession, sir. So they tend to commit many acts, but we feel many a time people who have the aggressive obsession will not commit suicide. That's kind of understanding that we usually have, sir. So what is the instance of people who have the aggressive OC committing the suicide, sir? Any evidence or literature on that, sir?
I am not specifically aware of the instances of suicide in aggressive obsessions per se, but in OCD patients as a whole, there is about 5 to 10% incidence of suicidal thoughts and acts. But I think one important thing to understand is I have come across many OCD patients with ego-dystonic suicidal thoughts.
Okay.
That is, their suicidal. So when you get a patient with OCD who also says to you that there are thoughts about suicide, you must differentiate between whether the suicidal thoughts are ego-dystonic, that is, they are more obsessional in quality, or whether they are actually suicidal thoughts where they intend to carry it out. Why? Because, see, somebody with OCD who has ego-dystonic suicidal thoughts, actually the risk is low. I hope you're able to.
Yes, sir. I understand.
Yeah. So actually there the risk is low. We don't have to confuse ourselves, thinking that we need to step up the management there. But on the other hand, if they are feeling demoralized as a result of their OCD, or they are in secondary depression, they're having a depression secondary to OCD, and so that's a different thing. So these two suicide, I have come across patients of both these categories, and I think it's important to make this distinction.
Yes, sir. Interesting. Thanks for the delineating point for this, sir. And sir, one question, the last question in the chat box, is about CBT. Sir, we have many formulation for depression, the Beck's formulation, Salkowski formulation, Clark's. So since suicidality in mental illness is very unique factor to handle, is there any specific psychotherapy related formulation to handle this thoughts one by one? So this is how we have to present that.
Yes. So in one of my previous papers titled "How do repeat attempters differ from first timers?" So what we try to see there is, so we had about nearly around 700-800 patients data, if I remember correctly. Paper was published in the Journal of Neurosciences and Rural Practice. I'll try to share that if I later with that, which you can share. So we try to look at first-time attempters versus multiple attempters and see what are the differences between them in terms of their demographics as well as their cognitive patterns and some of the other scales that we were using. And then in the discussion, we proposed a theory which combines the Beck's, actually that is posted by somebody in the chat box also, that is the cognitive mode theory by Beck, and then the strain theory, which is also by Beck. So it's like an amalgamation. So what it says is, see, if somebody has a lived experience of suicide, either in the family members or in their own life, they have now the suicidal mode is activated in the brain. Okay, what they say is the suicidal mode is activated in the brain. That's a cognitive mode. And with each successive attempt, the threshold of stress that is required to activate that mode gets lesser and lesser. Something like a kindling hypothesis, which we understand in many recurrent conditions. So what this means is, when I have already attempted suicide, the threshold at which I will consider suicide in the face of psychosocial adversity in subsequent episodes of stress will be much less compared to the previous. So if we So this is a cognitive formulation. Once we do this cognitive formulation, then we can begin to work on a therapy where we can address this in terms of safety planning and other coping strategies that we can use to distract the patient and try to look at alternate modes of coping when they feel a mental health crisis, when they experience a mental health crisis next time. So it is the cognitive mode theory as well as the cognitive strain theory, which can be combined. So this is kind of the model that we presented in our paper on how do repeat attempters differ from first timers.
Thank you, sir. Thank you, sir. I think it's time to wind up, sir. So thanks for the great presentation that you have given.
Yeah. So just if I may be allowed to just make one comment, I can see many a time there are other comments also in the chat box. I fully understand that due to want of time, I'm not able to answer, but I have already shown my email at the end of my presentation, and I can also share it with the organizers. If any of you have any queries, you can mail me, and we can take up the discussion later. Thank you so much once again for this opportunity to all the organizers. Thank you very much. Thank you,
sir. Thank you, sir. So let me introduce the speaker for the coming session. Dr. Suhas Satish, MD, PDF from NIMHANS. Currently, he recently joined as assistant professor in Department of Psychiatry in NIMHANS, Bangalore. So next month, 25th of September, we have the Evolve session 4 on the topic deconstructing the schizoaffective disorder. So hope we will meet on the another session on next month.
Thank you, Dr. Vikas, for your wonderful presentation, and thank you, Dr. P.P. Kannan, for sharing your valuable times. And thank my colleague, Dr. Nurul Hasan, Dr. Aswath Babu, for making this webinar a wonderful one. Thank you all. And we'll have, as Dr. Nurul Hasan said, we'll have the next month, CME will be on 25th, the webinar will be on 25th by Dr. Sugas. Thank you very much for all the audience for your participation. And a lot of queries are there. As Dr. Vikas Menon, his mail is there, the email ID, so that you can mail to him and he will reply. Thank you, Dr. Vikas. Now I thank the sponsor, Dr. Yusuf Pharma, and I ask them to give a vote of thanks.
Yeah, very interesting days, deliberations, issue which has a very deep social relevance. Thank you very much, Dr. Paneerselvan, Post Director, for having brought yet another very interesting topic to the Evolve platform. The public never saw psychiatrists as people who could save lives. They only saw psychiatrists as people who could make life easy for them. Now, this is the change in paradigm that has happened today. And I'm sure with increasing awareness, I always felt that psychiatry is the most human of all disciplines. Because you don't get a chance to look at the organ that you treat, but then it's all judgment. And Dr. Vikas Menon has brought, has demystified, as he himself put it, this suicidal risk assessment and formulation. And if we can intervene, as Dr. Kannan also, Professor Kannan also said that about 1.4 lakh people we lost to death by suicide. I hope Vikas Menon will understand. I didn't use commit suicide. Death by suicide, and there is a great emphasis has to be there in risk stratification and intervening at the right stage. That's exactly what doctor's message was. It was a wonderful day session, and the way Dr. Aswath Babu as well as Dr. Nurul Hasan moderated brought more insights into the topic. I'm sure all of you together are making Evolve an excellent platform for clinicians as well as the junior residents to get more updated about the recent approaches. Thank you very much for everyone. And we look forward to the next topic that is on the 25th of next month. Thank you very much to all of you for having taken time and discuss this very relevant topic. Thank you, sir.
Thank you.
Thank you.
Thank you. Thank you.
Vikas, sir, thanks a lot, sir, for accepting our request. Thank you.
Always a pleasure, Nurul. Thank you so much.
Thank you, Dr. Vikas.
Thank you, Paneer sir. Thank you, Paneer sir. Thank